might be that what Jean is going to tell us might be the treatment for these two. I'm not sure, but the first patient is a 58-year-old male. He came to the clinic with Hep C since about 1980, 1981. He said he took interferon and a handful of pills for about 1 week at that time, and then he has not had any other treatment. He started using in his early teens, went to IV heroin, coke, meth. About October 2019, he said he was just sitting in a cardboard box and looked at all the abscesses all over his arms. He was homeless. He was wanted by the authorities, so he turned himself in, went to prison. He had also drank alcohol for about 10 years. He thinks he got Hep C from tattoos, but he's not sure. No blood transfusion. Shared some supplies, but he is currently sober. When he came in for 26 months, he's living in a sober living house and working full-time as a fry cook. And to look at him, you would think he was healthy. You know, he's a big guy, but his ultrasound showed some nodular configuration of the liver, no masses, but cirrhosis. Size was 15.8. His vital signs, blood pressure was stable, weight 263, BMI 35.7. Other comorbidities was hypertension, hyperglycemia, obesity, vitamin D deficiency, osteoarthritis of the knees, and his history of stimulant and opioid IV use. His medications on down are atenolol, lisinopril, Celebrex, Zyrtec, ropinirole, mirtazapine, lactulose, Colace, metformin, vitamin D, and he is on Suboxone, and that's 16 milligrams a day. He is immune to A. He was not immune to Hep B. We've given him the vaccines, and we might have a follow-up on that last vitamin B, Hep B, I'm not sure. But we go on down to his labs, he has leukopenia, his white cell is 2.7, hemoglobin 13.8, platelets, first one is 57, INR 1.1, PT 12.3, his albumin 3.9, ALT 192, AST 238, APRI 10.4, child Turco-Pew was a 5, class A, and his MELD score was 10. His genotype is 1A, his viral load was 4,570,000. His fibrosis marker, 0.96 or F4. And I believe that other, that 138, I think that was his sodium level. But he also complained of bright red rectal bleeding on and off for the past year, no external hemorrhoids. So I referred him to GI for the endoscopy, colonoscopy. He didn't show for the first appointment. We have called to reschedule that. So I was wondering if I should ask GI to go ahead and take care of the Hep C, or can he be treated, or does he need to be on a transplant list, or just treated for end-stage Hep C. I'm not sure.
Thank you so much, Tammy. That was a great case and very detailed. So thank you. We appreciate it. Before we go into any of the recommendations, did anyone have clarifying questions for Tammy?
Do we have, hi, my name's Suzanne. Do we have any evidence of him clearing the first time he had Hep C?
No. No, and that was like about over 40 years ago. But he only took interferon once and pills for about a week. So I don't think he would have cleared, but I'm not sure.
Well, hey, this is John. Can you guys hear me okay?
Yes.
Perfect, yes.
Yeah. So there's a dubious component of his history. He's not recollecting correctly because there was no ability to diagnose hepatitis C at 1980 to 81, nor treat it. So remember, the diagnostic tests for hepatitis C weren't until the early 90s. 1989 would have been about the absolute earliest, but most people not until early 90s. So he definitely didn't get diagnosed in 80 to 81, nor did he get treated, because that wasn't possible. Just to clarify. So and yeah, I would consider it non-consequential, this prior treatment. He's probably got a vaccine. A lot of people get confused about what a shot they take is. It had been my impression in the past. When I hear people tell me they've taken a shot and a couple pills, it's often a misunderstanding of what they were given. That's a long time ago. And heck, the guy's got mild encephalopathy apparently with lactulose use, so we'll give him a pass.
Thank you so much for that.
So I guess the question is, well, not question, but concern is like compensated versus decompensated cirrhosis, and the guy like him with Hep C, and then that kind of limits our treatment options, then we're, pushing one way or the other. I would obviously wait for GI to kind of make a call, just because I had a patient similar to this where it was not very obvious if she had decompensated cirrhosis or not, but she was F4, and we were trying to figure out, okay, based on just liver ultrasound, can we make that call? And she was on anticoagulation, so it was hard for us to rely on that scoring system for her. So we ended up waiting for GI, and then we couldn't get the EGD, but then eventually GI made that call for us to call it whether it was decompensated versus compensated cirrhosis. So for him, I would definitely encourage that GI evaluation before we start him one medication versus another. I don't know what everyone else thinks, but I would be safe than sorry.
Hey, this is Jane. Can I make a comment?
Absolutely.
Can you hear me? Okay. So I'm Jean, I'm from hepatology. So my initial concerns with this guy, first I was thinking about decompensation. I mean, a lot of times they may have some mild forgetfulness or something, or maybe some constipation that gets stuck on this lactulose. So I don't know if he has decompensation or not, but his AFP is concerning to me. I've seen people get treated on AFP and it ends up not being an issue, but if this guy has cancer, that should be addressed before he gets started for hepatitis C treatment. So he needs an MRI. I think I saw that he had an ultrasound, right?
Right.
Is that right?
Yes.
Okay. So I would start there. And as far as, transplant goes, he has a MELD score of 10. That's not close enough to even consider for transplant. Usually somewhere around 15 to 17 is where we want to start thinking about transplant. So I think at this point, he's way too early for that. So if we can resolve some of the other stuff and get him treated, maybe he'll never get to transplant. That would be the goal. As far as the GI bleeding, I mean, unfortunately, he no-showed to that first one. We have a ridiculously long wait, but it looks like he's on an NSAID, right? BID.
Right.
He needs to come off of that completely.
Yeah.
For a couple of reasons. The NSAIDs are going to probably contribute to whatever bleeding he's having, but also in liver disease, people that take NSAIDs can cause renal failure. So they really shouldn't be on this if they have cirrhosis.
Yes, we addressed that, and he says, well, my knees, I can hardly walk without it. So I'll emphasize
I mean, he
that
could take
more.
Tylenol. He could take Tylenol.
Yeah, that's what I told him, to take Tylenol.
Yeah. Yeah.
Okay. Okay. Thank you.
Hey,
Sure.
Tammy,
Uh-huh.
Gene, great comments.
Thanks.
Yeah, pertinent for today's talk. Hey, in terms of therapeutics, this person is having a uncertainty as to whether they're compensated. Labs look compensated. Clinically, it sounds like he's rated a child's Pew A, so we think he's compensated cirrhotic. But if you had to choose, your therapeutic, I'd err towards Epiclusa. Remember that the protease inhibitor regimens, Vicira and Zepatir or Mavorite. Mavorite's our usual go-to, but remember it's a protease inhibitor. So you got to be careful in child's B or C or any decompensated state, because they require a little bit more aggressive monitoring of your liver enzymes. And so steering towards the Epiclusa or Harvoni would be the way to go. And I agree with Gene. That AFB hopefully will just get better, but that's an assumption we don't want to make. So an MRI and yeah, and I'm less worried about referring them to GI for treatment. I think you can do that, no worries. The treatment part, but I would make sure they established with a GI for cirrhosis management. Cirrhosis management's a challenge. And so they'll need long-term endoscopy follow-ups and HCC monitoring and all that other stuff long-term. And who knows if they'll need help with getting on a transplant list eventually. So definitely having a GI doc in their life is a great idea long-term.
Okay.
But you can treat
right.
them. I think you'll do great.
Thank you very much.
Thank you all so much for the great comments and feedback. Tammy, were there any other questions about this case before we go to your second one?
No, I think that answered my questions.
Excellent, sounds good. Let me pull up your second case here. All right, I'll turn it to you now, Tammy.
Okay, here's another guy, similar, 62-year-old male. He was born club-footed, had many surgeries. He said he was made fun of. He couldn't play basketball, was very depressed. When he was 18, he learned how to box and got in with a lot of boxers. And by between 18 and 20, he was drinking in the bars, and marijuana, then Valium, Quaaludes, and then painkillers, where he was in the hospital so much. And then meth came along, and that was his drug of choice for years. He said he cooked it and sold it and was using it about 6 times a day, and he was drinking along with it. But finally, he had like some sort of spiritual awakening about 7 years ago, and he has not used since. And he is often on the streets trying to help other people. His ultrasound showed no focal hepatic lesion or ascites. The size of his liver was 11.3. And he's had some heterogeneous echogenicity of the liver. His weight, 141, blood pressure, 117/87, heart rate, 78. His comorbidities, possibly cirrhosis, history of alcoholism, vitamin D deficiency, hiatal hernia, deformity of his nose, and thrombocytopenia, leukopenia, former smoker. His only meds have been vitamin D and pantoprazole. He has had his Hep A, and he's immune. We were giving Hep B. So his labs His white cell, I've repeated it several times. It's been 2.8, 2.7. At this time, it was 3.3. Hemoglobin 15.5. Hematocrit 44. Platelets 100. But it has dropped lower, like in the 70s and 80s. His glucose was 85, creat 0.9, proton 11.9, INR 1.1, albumin 4.3, his ALT 121 and AST 81. His a pre 2.025 child Turco-Pugh class A, and his MELD score was 7. His genotype was 2B, viral load 1,210,000. His fibrosis biomarker was 0.88 or F4. Let's see, his Hep B core was negative, sodium 141. Also referred him to GI to check for varicosities or other abnormalities. And he went and had an esophageal dilatation, and then they set him up for an EGD, but not till June. And so I was, wondering the same thing about him. And I mean, I was thinking he should have had the EGD sooner than June. And is it okay to go ahead and treat him, or should I refer him to GI, or just need some help on this one too?
Thank you, Tammy. Another great case. And if anyone needs to refer back to the case form, just let me know. I'll pull it back up. Any clarifying questions before we jump into the recommendations? And anyone feel free to chime in, unmute, raise hand feature. All right, and any comments, feedback, recommendations from the hub members? Dr. Gilfus, I see you unmuted there.
Yeah, man, Tammy, you got some sick patients. I'm impressed. Yeah, these are, I'd say in the last two cases, not only should you feel comfortable treating, you should, consider that these people really need to be urgently treated. So, and I concur with you getting them established with GI. I'm going to defer to Jean as to, the order of esophageal varices screening versus the dilatation. It looked like, and also as to whether or not he really needs the pantoprazole. The CBC, you mentioned the leukopenia, and I'm really glad you picked that up. It's a scary thing to see when you see patients who are leukopenic, but that often does run along with cirrhosis and chronic liver disease, or late stage liver disease. So leukopenia and thrombocytopenia, absolutely classic CBC findings. And fortunately, it looks like liver synthetic and bio, so INR and albumin look great. Bilirubin is normal. So at least the liver is doing what it's supposed to do. And it sounds like he's compensated. So he's a compensated cirrhotic. Your treatment options here for genotype 2 are going to be Epclusa or Mavorite. And I sort of echo what I said last time. All things being equal, if he can come off the pantoprazole, Epclusa would be probably choice number 1 for 12 weeks. Otherwise, Mavorite for 8 weeks. And I just monitor his liver enzymes. If you do go to a protease inhibitor, just make sure you don't see a spike in those AST and ALT after a couple weeks. And then periodic monitoring thereafter, probably about every 2 to 4 weeks. But yeah, I think you're doing great. And just like the first case, long-term HCC monitoring will be a must. So, but yeah, good.
Yeah.
People are lucky they ran into you. Get them get him treated. And yeah, ideally, I would love it if they could come off the pantoprazole, but not sure if that esophageal dilatation was due to reflux or the stricture was anything from that perspective. The GI doc made, I mean, I want you to stop it. Gene, I wasn't sure if you had any comment on that one.
Yeah, so I want to say this guy sounds like a great candidate for treatment. I would treat him probably with Mavyret or with Epclusa, either one, just depending on, how long he wants to take the medications. I think I see better response whenever they have shorter duration, but sometimes people don't like that extra set of pills that go with the Mavyret. So whichever works for you or him, I think he's a great case. He's got low meld. Sounds like he's very stable. He just needs screenings, every 6 months at least from here on out, just because of cirrhosis. But it sounds like he doesn't have any complications. So good for him for running into you.
Yeah.
As far as the EGD, unfortunately, we're scheduling like in November. So to be in June, I don't know when he was originally scheduled, but to be in June is pretty good. I really don't have a better short-term solution for that other than if he's actively bleeding and we hospitalize him, they get scoped there. We're trying to remedy that, but we just haven't been able to be successful in that yet. We have lots of docs here, lots of people scoping. We just don't have the space for him to scope in. And that's part of the challenge. We just can't get them in the door. So unfortunately, June is pretty reasonable for that, but I don't think you have to wait on that in order to treat him. I think you could go right ahead.
Okay.
This
Yeah.
looks like a great candidate.
Okay. Yeah, he's chomping at the bit to go to Kentucky and drive an inloader all summer. So wait a minute. Let me check. Yeah. Okay. Well, that sounds great. I'm sure he'll be pleased.
Yeah.
Thank you, guys.
Thank you all so much. Any final comments or recommendations for Tammy's case before we go to the next one?
I just wanted to piggyback, this is Rachel, on what Dr. Gilfus had mentioned, whether you can come off the pantoprazole or not. Just keep in mind, if you would go the Epclusa route, they didn't actually do the PK studies with pantoprazole. The package insert does specifically say the omeprazole or Prilosec 20 milligrams. So if he's not willing to come off the PPI, he can still take it, but they do recommend doing the omeprazole 20 milligrams with that one, rather than the pantoprazole, which you can prescribe separately, or that is the over-the-counter dose that you can use for it. Alternatively, if you wanted to switch them to like an H2RA, like the famotidine or something, that's fine too. Or, best case scenario, like Dr. Gilfu said, if he doesn't need it for some reason, if there's not an underlying reason, just, hold it for the 12 weeks if he was on it with the Epclusa. And that's specific to the Epclusa. There's no concern with that in the Mavyret.
Okay. I meant to mention that he was not on that until he had the dilatation recently. And his complaint was that he was having difficulty swallowing. That just sort of happened. Suddenly, it wasn't a long-term thing. And so has recently been put on that. So I think we can either change it or maybe stop it. Thank you.
Excellent. Thank you, Rachel, for that final comment there as well. Tammy, any other questions about your case?
I don't think so.
Awesome. Well, thank you so much for your two cases. We really appreciate it.
Thank you.
Robin and Amanda, I have your case ready to go. Amanda, thank you so much. Big shout out to you for hopping on here and doing the case. I know, Robin, you're a little sick, so I hope you feel better. Are you able to see that okay, Amanda?
Yes, after technical difficulties, yes. See it.
No
So Robin, I said, I can't get my camera to work.
No worries at all. We're happy you're here and we can hear you just fine.
Okay, so this is one of our patients. He's a 30-year-old male. He started smoking marijuana when he was 12 or 13. He's using IV drugs at 20s. He's been clean for about 8 years now. He was diagnosed when he was admitted to a mental hospital in Pennsylvania. That was when he started to get clean. He's on Aristata right now, IM injections for that, and he seems to be doing fairly well. His immune to Hep A and Hep B. We added vitamin D because of his labs being low. His APRA score, we looked at it at first following up with an ultrasound, but then when his fibrosis markers came back F0 to F1, we decided that we didn't need that. So his viral markers were 0.27. His viral load is really high. So we're trying to get him treated as quick as possible. He is genotype 3. So we decided that his MAVRIT times 8 weeks would be better. I think that the shorter they're going to do it, the longer, I don't know if they'll be committed. But other than that, do you guys have any questions?
Thank you, Amanda. I know that was your first Echo case presentation, so awesome.
Been a lot of years.
Thank you so much. Any questions for Amanda and the case she just presented before we hop into the recommendations? And any recommendations, feedback from any of the hub members?
Hey,
Dr.
Amanda.
Gilbert?
Yeah, great job, Amanda. It's a good time to catch this guy. You know, he's young yet, and doesn't have a lot of fibrosis, so great time to get this out of his life. And you know, your genotype 3 non-cirrhotic patients, there's no extra testing to do, so you don't have to do the any funny polymorphism tests or anything right now. So you can just go ahead and treat them. And I agree with your choice 100%. MAVRIT for 8 weeks would be great. And Epclusa is your other option, a little bit longer for 12 weeks. But I would do the choice you did, MAVRIT, and go for it. Remember, natural history there tells us with genotype 3, this is when we want to treat him, because he might have a more accelerated course. What worries me most is his genotype, even more so than his viral load or anything else on there. So you're right on. I got nothing else. And I think he doesn't need any long-term HCC screening. I agree with you on deferring the ultrasound. Really cannot make it pertinent with that friendly looking APRI and serum biomarkers. So good job. Well done.
Thank you.
Thank you, Dr. Gilfus. And Rachel, I see you unmuted.
Yeah, I was just going to add in with the Aristata, so with that IM injection, so there's just a monitoring recommendation with that in the MAVRIT, just because of the interaction there, that CYP3A4 interaction, because of the protease inhibitor. So it's specific to the MAVRIT. It's not a caution with the Epclusa, but just something to monitor, because the aripiprazole, that Aristata, has a narrow therapeutic index, and since that's the longer acting, that extended release with that IM injection, just a little caution to monitor for potential toxicities when giving the MAVRIT with that, just because, you know, the typical things we look at with the antipsychotics. So QTC prolongation, if he has any cardiac history like that. I don't suspect any seizure history, CNS depression. Those are just those sort of things that we monitor for when given the aripiprazole with the MAVRIT. I can't recall specifically a patient that I've encountered on the IM formulation, but I've had many patients take the MAVRIT with the oral formulation and do just fine. But just something to be aware of when they get started if you do go with the MAVRIT.
Thank you so much, Rachel. Any other comments, feedback, recommendations? And Amanda or Robin, did you two have any other questions about your case that you wanted addressed today?
No, not really. I don't think Robin does anyway. I wish she could talk and say something, but no, from what I understand, we don't.
Thank you so much. We really appreciate you presenting today. And I do want to give a big apology to everyone. We kind of skipped the intros today, and I just thought of that, but we did have a packed session, so I wanted to be mindful of the time a little bit more. So if you would want to chat in your introduction or anything, please feel free to do so, but apologies from me on skipping the intros. Jean, if you are ready, I can pull up your didactic for you, and I'll just turn things over to you.
I'm ready.
Ready. Is everyone able to see that okay?
Except me, I probably need my bifocals. You can go ahead and turn the page. So my name is Jean Colonel. I work in hepatology. I'm advanced practice You know, I've done liver disease now for about 16 years. I kind of fell into it by accident, but I worked in a transplant center before coming to West Virginia, and it really became near and dear to my heart to deal with liver patients. I used to work in a prison, so the people that have some of the more exciting lifestyle that leads them to liver disease, I can understand where they came from and that kind of stuff. So I really do like this role. But anyway, that's beside the point. I just wanted to let you know, there's a difference in cirrhosis. So you can have cirrhosis for a long, long time. You can do just fine. Or you can have cirrhosis and really cause a lot of problems for yourself. And so that's what I try to tell these patients. So this is basically the presentation. I don't do it on PowerPoint, but this is basically what I tell patients. So you can have cirrhosis from multiple causes: viral, autoimmune, drug-induced liver injuries, genetic problems, metabolic problems, all kinds of things. Once you get to cirrhosis, we don't measure it past that. So you either have stage 4, end stage, final stage, advanced, whatever word you want to use, but cirrhosis is cirrhosis. You're either compensated, meaning without complications, or decompensated, and that's where the problems become an issue. So if you're decompensated, we have to do other stuff. But basically, the management of cirrhosis is the same for both of these things. It's just managing complications that we have to also pick up at the end. Okay. So you can turn the page. Okay. So what I tell my folks is, once you get to cirrhosis, and lots of times that's where I see them at, they already have cirrhosis. They come to me, they've been terrified by whoever they saw. They've been told, they're going to die in 6 months. They need a transplant. They're going to die. That's like the common theme that I get told. And so what I tell these folks is, first I ask them, why do you have cirrhosis? And most of the time they don't know. But anyways, we have to figure out the cause. And if we can figure out the cause for cirrhosis, then usually we can try to prevent additional damage. And that's really what it's all about. So again, there's, all of those causes are listed there. I mean, obviously I didn't do any of the detailed junk with that, but I think on my previous PowerPoint, or maybe 2 ago, there was a listing of all of the different varieties of liver disease that can come up. Once you have cirrhosis, then it's about preventing the complications that come along. And really there's 4 main ones, swelling, confusion, bleeding, cancer. That's really what we're worried about treating or managing or preventing. You can have other things that can happen. Of course, you can have blood abnormalities, you can have electrolyte abnormalities, protein malnourishment, etc. But the 4 main complications are the things we want to focus on. Okay. So they have lots of complaints, and some of these complaints, really are not treatable. They have profound fatigue, they have nausea, they have, weight loss is undetermined. As long as it's not severe, there's nothing to do for it. Their spleen is too big, their belly is uncomfortable. They have bruising on their arms, or they have a blood clot that nobody knows what to do with. All of these things as a baseline are not treatable. Now, if they're severe, we treat some of this stuff, but really it's just about screening it out and sort of learning to live with it. The mild nausea, Zofran is a good option if they don't have cardiac disease. The weight loss, I just tell them to drink more protein, eat more protein. The spleen, we can't do anything about. It does get very large in some people. They're very uncomfortable. They cannot have their spleen taken out. It's very dangerous. It's life-threatening for these people. The lab abnormalities, lots of times I see low sodium levels, serum sodium in these patients. And honestly, there's nothing we do for it unless it becomes less than 125. These people sometimes live at 125, 126. That's their normal. There's no need to fix it. They don't have symptoms. They're doing just fine. But if it's 117, that's a problem. Sometimes these people are normal with that too, but we don't like it to be that low because they can have neurologic changes at that point. The blood clots, that's always a sticking point. Cirrhotic patients are never a good candidate for blood thinners. Hematology often puts patients on, for blood clots. That's what you do. You put them on blood thinners. But for a cirrhotic patient to be on a blood thinner, it can be really dangerous because they can spontaneously bleed from any of the varics within their entire GI system. We've had people bleed in the brain, which of course, there's no way to screen that out at this point. But I mean, it's just very, very dangerous to put a cirrhotic patient on a blood thinner. And then the bruising, of course, again, they have sort of almost like a DIC problem. They have this clotting disorder, but then they're bleeding too much. We really don't do anything for it. We just monitor it. Okay, go ahead and turn it. So these are the 4 main complications that I mentioned. So, you get compensated cirrhosis. The risk of developing a complication is about 5% or so a year. Once you have a complication, the risk will change. The biggest risk you would think would be cancer, but cancer is really not the biggest risk. The biggest risk for these patients is encephalopathy, because their thinking is really what messes up everything else. So if they get confused, they start having problems with their medications, they start missing appointments, they don't do all their screenings, they don't, they take the wrong pain med or whatever. They start having more problems when they have a thinking problem. But the patients complain the most about ascites. That's the one that the patients are really uncomfortable. That's the biggest complaint for them, but that one actually has the best outcome overall. Okay. So, encephalopathy or confusion, it can be brought on for a multitude of reasons in cirrhosis. And it really is on a continuum. It can go from really, really mild, almost unobservable by a practitioner, to in a coma. The mild stuff is usually picked up by their family members, people that live with them, or work with them. They notice that, they're just not right. There's nothing they can pinpoint, but they're just not right. Or they seem slow to, make change from $1 or doing their daily activities. They're just not right. There's really not anything to do with it whenever it's really mild like that. They need to eat protein. They need to be making sure they're having bowel movements. You can put them on lactulose. If that works, great. Keep them on the lactulose. Don't take it away. The biggest thing about lactulose, of course, is then you don't want them to have diarrhea. So they need to increase it and decrease it. And that's a big piece that a lot of people don't understand. They don't understand that they can take it 4 times today, and 1 time tomorrow, and 3 times the next day. That's fine. It's all about keeping their thinking clear. We don't draw ammonia levels outpatient. They're useless. They're inaccurate in a cirrhotic patient. They can be really high. They can be coherent. They can be really normal, and they're totally confused. So there's really no reason to draw those unless they're inpatient and you're trying to filter something else out. Old information said, limit dietary protein. We don't do that anymore. These people need protein. It used to be common practice that, protein was causing the liver to have more breakdown, causing confusion. That's not accurate. That's been disproven in research many times over. As far as encephalopathy, you also want to limit any kind of sedating medication, not just narcotics, but anything, benzos, sleeping medication, antidepressive medications, all kinds of medications that can have any kind of a side effect that can be sedating for any person. It's much more profound in somebody with cirrhosis because it gets filtered through the liver. And what I tell people is that sometimes it sort of gets gummed up in the liver. It won't filter out. And therefore, it's sort of sluggish moving through. And it causes additional confusion. It's hard to know if it's from the liver or from a drug. Okay. Variceal hemorrhage. This one's pretty scary. So like that guy that we were talking about on one of the presentations, if you have bleeding, you want to stop everything that could possibly cause bleeding. Because unfortunately, if they start vomiting blood, there's no way to stop it. Unless it stops on its own, there's no way to stop it. These people can literally bleed to death in minutes. If this is a huge hemorrhage, it will cause death. So honestly, they shouldn't take any kind of NSAIDs at all. If they're like that guy didn't want to come off of his NSAIDs because his knees bother him or, whatever their complaints are, try to give them something else. If you can, finagle gabapentin, if you can get, low dose Lyrica or anything else, amitriptyline off label, all of those other things work well if you can get it in low enough doses that it doesn't cause bleeding. Because once they start these bleedings, they have an almost 60% chance of death every time they bleed. I mean, it's really, really high. So we want to try to prevent that as much as possible. Rectal bleeding, really holds a whole different ballpark of ranges and problems. But the upper bleed that we see, that's the one that's so just devastating. The lower bleeds, lots of times we pick it up, it's a slower bleed. It's more of an oozing. We see it in the stool. Patients are, they complain about it for a while, but they don't generally bleed to death that way. So again, we want to try to prevent all this stuff. We do put them on beta blockers if they can tolerate it. So there was a complaint that I got recently from somebody that said, the beta blockers are not indicated in somebody that has ascites and on diuretics. Well, that's actually been disproven. If anybody's interested in reading the American Association and Guidelines on Liver Disease, it's called AASLD. They have a huge write-up on ascites if you're interested. And they have really nice bulletin point recommendations on what to do. But one of them is to continue that beta blocker. It's safer to give them beta blockers, prevent them from bleeding to death, than to worry about an interaction with a diuretic. Sometimes these folks need serial EGGs, and this is why we get so behind on our regular EGG surveillance studies. Some of these people are needing EGGs every 2 weeks, every 4 weeks, every 6 weeks. Once we finally get them stable, then they don't come back for a year, but sometimes they're back and they're back and they're back, getting lots and lots of banding, and they're really uncomfortable when they get those done. They have a hard time swallowing, they have chest pain, they come up with all these other complaints. And so that's why we're so far behind getting just general surveillance done for everybody else. Okay, next, ascites. This is the one that everybody complains about. All the patients complain about this one. This is like the least of my worries, generally speaking, but this is the one that patients are most miserable with. I do paracentesis here at the bedside. Anytime a paracentesis is done, they should really have albumin infusions. Anything over 5 liters taken off of the belly, they should have albumin given in an IV. The reason for that is when you take that fluid out of the belly, it shifts their body fluid, can cause cardiac malfunction, can cause renal disease and renal failure. So if you're going to take that much fluid, you want to give them albumin to counterbalance that. And anybody that has questions on how to order that or how much to give or whatever, you can always message me and I'll tell you individually for the patient. But I do them here at the bedside just because it's a little faster than going through IR most of the time for these folks. I just do it as an office visit and they can walk out within the hour, which is kind of nice for them. I do not recommend any Florex catheters for anybody that has chronic ascites. The reason being is they can develop SBP. If they get SBP, which is spontaneous bacterial peritonitis, if they get that, the statistics show they die within 4 to 6 weeks. I just had some guy who had, now granted, he had cirrhosis, had hepatitis B, he had liver cancer, and he had cancer thrombus. So he was end stage disease. I mean, this gentleman was dying. They put a tube in him. He died literally at 7 weeks. He died the day before Valentine's Day, and it had been 7 weeks almost to the day when he died. So, I mean, they have a place, especially for somebody who is on hospice, who, doesn't want to do weekly paracentesis or can't do, and they can't get to the hospital or whatever. But just know that if you put a Plerex catheter in somebody, they will die from infection within just a couple of weeks. The recommendations for these diuretics, a lot of times people are really uncomfortable with the doses that I hand out. Not the patients. The patients feel great. The providers are very uncomfortable with the doses that I put these patients on. Lasix, sometimes I go all the way up to 160 a day. Spironolactone, I sometimes go all the way up to 400 per day. Now, this is the recommended doses on the Liver Disease Guidelines website, because the liver just can't filter it out and it's just dumping it through the body. So we just have to help the body sort of get rid of it. Lots of times when they have this massive fluid, they cannot eat and they end up with this protein malnourishment. So we sort of have to try to work with that as well. We want them to have, high protein diet, protein with every meal, every snack. Sometimes they get fluid into their lung. They need thoracentesis regularly. Don't stick a tube in there either. Just drain it and do it again next week if you have to. I don't know what else to say about fluid, but honestly, that's the one that patients complain the most about. Okay. Then liver cancer. No patients ever complain about having liver cancer. It's asymptomatic. They complain about the treatment sometimes, but it's asymptomatic and they don't even know that they have it. They have this ginormous liver. Sometimes they have huge lesions in their liver, 10 centimeters, 14 centimeters. I saw a couple of times recently. They don't even know that they have this thing in there because the liver is very accommodating. So, you know, you get these giant lesions and they just grow and the liver just moves around them. But these people, when they get big like that, they can't be treated. So they have to be less than 5 centimeters to be a candidate for transplant. And they have to be less than 3 to 4 centimeters with other lab testing in order to get treatments like TACE or tear procedures, chemoembolizations. So they have to meet certain criteria in order to get treated. And that's why I recommend ultrasound alternating with MRI twice a year. You know, the MRI is going to be a better image. It has to be done with and without contrast. You know, if it's done without contrast, we can't see inside the liver. It really doesn't help us. We can see bile ducts, but we can't see liver tissue. Also, that goes for the CT scan as well. You know, you have to have contrast or we can't see inside of the liver. People with liver cancer can sometimes qualify for transplant if they meet the criteria. They get extra points for transplant, but you know, you have to get them set up for transplant before they get treated for cancer. So it's sort of a timing issue that becomes a problem. But nobody ever complains about liver cancer until they start treating it. Okay. Transplant. I get so many questions about transplant, you know. So I don't know if everybody knows this, but West Virginia does not have a liver transplant center. In order to get a transplant, if you live in West Virginia, you have to go to one of the outside hospitals. So you have to go to Cleveland Clinic, or you got to go to Pittsburgh, to UPMC or AGH. Got to go into Baltimore, Maryland, or you got to go down to Virginia. All of the centers have different criteria on who meets transplant criteria. But for the most part, if you have certain things, you get disqualified immediately. If you have an active infection, you get kicked out. So people that have recently, you know, they're really, really sick with liver, but then they get COVID, they get bumped out and they don't get a transplant because they have COVID until it gets better. And sometimes it doesn't get better because these people are so sick. If their BMI is greater than 40, some centers are even more restrictive. You know, they want it to be, you know, under 38. But if it's greater than 40, they're definitely going to be disqualified. If they have severe malnutrition, they're disqualified. Active alcohol use, even with an acute alcoholic hepatitis, actively drinking that has active liver failure and fulminant failure. The only place that I know of that will take these people sometimes is Baltimore. I don't know that Virginia will take these folks, but I know Cleveland Clinic and Pittsburgh will not. And most people I've found in West Virginia have West Virginia Medicaid, and they can't go anywhere but to AGH. Some comorbidities will exclude you from transplant. So for example, if you have bad heart disease, they're not going to take you. You have pulmonary sarcoidosis, they won't take you. Pulmonary hypertension won't take you. So all of these things are, you know, disqualifiers. You know, some centers will do dual organ, so liver lung or liver kidney, liver cardiac. I don't know of any liver cardiac up here in this area. The only one I'm aware of that does that is in Louisiana. But, you know, to do a dual organ, they really need to be really close to these centers because they have so many needs and so many restrictions and expectations to meet criteria. Unfortunately, social support is a huge one that I find to be a challenge here. You know, you have to have a car, you have to be able to get to the AGH or wherever, whichever facility, within 6 hours. You have to respond immediately by phone if they call you, you know, so you have to have a caregiver, you know, so there's a lot of social supports that unfortunately seems to be a limiting issue for all of our folks here, it seems like. You know, schizophrenia will disqualify you, too large, too many liver lesions, and then too low of a MELD score. So, you know, something to think about for the transplant centers. So if you're following a patient here and their MELD score is 10, and you refer them to transplant. Okay. Transplant will pick them up, even though their score won't qualify them for the transplant. They'll pick them up and they'll monitor these people. But in order to stay at that facility, to be active, to be considered for transplant, they have to do all of the testing at least once a year at that facility. So, you know, if you're following them and they're following them, these people are oftentimes doing double work. And it gets to be a lot for these patients because they have to do it every year at the transplant center, or the transplant centers won't keep them. And if they no-show, now they're considered non-compliant. And so that's the challenge. I don't like to refer these people until it gets to the point where they need to be there, because otherwise they just carry them and carry them and carry them. And then it gets to be a burden on the patient, and then the patient gets up. And that's a problem, because then it gets a black mark against the patient, which is unfair to them, but that's how it is because there's not enough organs to go around. So, you know, I don't recommend referring anybody to transplant until their MELD score is really around the 16-ish mark. Some facilities will say 15 is their number. Some don't want them until they're 18. So somewhere around 16 is the best time. Okay. Oh, that's it. Good. I'm sure I was like, make it short, make it short.
Thank
So
you so
hopefully that
much.
was good.
I love that last slide too. The little liver was so cute. Thank you so much. We always learn so much from you. We just appreciate you so much.
Thank you.
I guess we can open it out for any comments or questions from the group. Don't be shy, everyone. We got a chat, and thank you, Tammy, saying that was excellent, and thanking you very much.
Thank you.
Did you
I know.
say, oh, I'm sorry.
No, go ahead, Tammy, sorry.
Did you say that sometimes you went up to 400 milligrams on the aldactone?
Yeah. Yep.
Wow.
Yeah.
High dose, isn't it?
It is. It is.
Any other questions, comments? You're always welcome to email Elizabeth or myself if there are questions afterwards, and we can send them over to Jean as well. Alrighty. Well, I'll give you all 5 or 6 minutes back to your day. I know it's not much, but I hope gives you a little more wiggle room for some other things you might have to do. But thank you all so much, as always, Tammy and Amanda and Robin for the cases, and Jean for the didactic. I'll be sending your didactic over in the recap email as well. I know that's super helpful for everyone. So my only announcement is that Victoria Kosinski, who's on today as well, will be presenting next time on drug interaction. So keep an eye out for that reminder. We're super excited to have you, Victoria. So we'll see you all next time. Take care, everyone.
Thanks.
Bye. Thank you.
Bye.